pearls and pitfalls in redo surgeries, and the amount of surgeries happening now in spine, I think redo surgeries is going to become one of the large number of surgeries that all of you all are going to be indulging in. So we may as well talk about it. This was a paper Vishal presented in the Masala Wala oration many years ago, Vishal. And this was about 53 cases of redo spine surgeries from a single unit that were presented prospectively. And there we found that 10% of the cases that we operated were redo surgeries back then, 15 years ago. And there we had, Vishal had made a very smart classification of what are the causes of failure, and this would be then the theoretical classification, which means that when you look at any case of redo, it would fall in one of these categories. It's self-explanatory, so I don't have to go through, I don't need to go through this. For those who want this lecture, please don't take photos, just take the lecture. The lecture is here, just take a pen drive and take it from there. It's for you. So don't bother about taking pictures because it doesn't represent, what I'm trying to say. I'm rather here to give you a technical classification. So as a surgeon, when you approach a patient, this is really irrelevant because now you're a surgeon, you're a technician, you're going to work on that redo. So a technician classification here would be, one type of redo would be the same patient but a different surgery. Another one would be the same patient, same surgery but in the adjacent region, which is so common. The third type of patient that comes to you would be the same patient, different surgery but in the same region. And then the fourth type would be same patient, same surgery, same region. That's how the difficulty quotient goes on. And let's try and zoom in on each of these. So same patient, different surgery, typical scenario. You've done a lumbar, now she's come back after 2 years for a cervical. Here the issues are expectations and familiarity. So you're clean because it's technically not a redo, but the patient has already had a successful surgery with you and now she expects the same results from the next surgery. And she's familiar with what went on. Kharcha itna hoga, itne 3 din mein reha kiya, all those things. And you got to reboot and recycle this to the patient and let her not feel that it's the same operation again. So be careful of those expectations. On the other hand, sometimes it can get sticky. So in a scene like this, where the surgeon had done a lumbar surgery, but the patient didn't get a good result, and presented eventually dragging his feet, came after two years, but then there was an adjacent pathology like this, which was missed. And here the issues of counseling are quite different because they're going to say, Pehla surgery barabar tha kya? Did they miss a level? Did they do that MRI? And there you have to kind of be on your guard. It could be your own patient. So, you have to ask what was the result of that first surgery. You have to be slightly protective of your colleague or yourself and make sure that you give the message right. But these are two different scenarios of the same surgery. I mean, a different surgery in a different level, but you got to approach it differently as the surgeon. Now, what about the same patient, same surgery in the adjacent level? That's the classic ASD. And I think all of you are seeing tons and tons of ASDs on a daily basis because of the amount of surgeries we do. There's a misconception that ASD only happens after fixation. And I'm going to stick my head out and say that ASD is not a result of fixation. It's a natural history. It's almost like saying that I operated your knee on the left side, and because of that, your right knee has become arthritic. That is bullshit. So you have tons of cases where you've done basic decompressions and they get ASD because it's a natural history, and you'll see more and more of them as you see, as you go into practice. Here's one case in point: laminectomy decompression done at a higher level, developed a disc at the lower level. I'm using this case to give you a technical tip on how to approach this as a surgeon. It's very important to zoom in on your AP X-ray. So when you're approaching this patient, you got to make sure that your landmarks are very well defined. So the AP X-ray actually tells you which bone is available to you to use as a landmark or as a lighthouse when you go in. Otherwise, you're going to dive into scar tissue and there's going to be leakage of CSF and noodles on your face, and then it's not a fun place to be. So you compare that AP X-ray with the MRI and you tell yourself, when I go in, the first small spinous process I'm going to see is whatever, L2 in this case or whatever. And then the lower one is going to be this, and then there's a big fat spinous process below it. You orient yourself with that AP X-ray, and that will give you the picture in your mind's eye of what you're going to see when you're out there in surgery. And after that, you localize your level. It's not, uncommon to actually miss and do something here and miss this level completely. And you got to be very sure of that. And hence, for me, the tip, the pro tip, as they say, is the AP X-ray. On another situation, when you've done a fixation and the patient comes with an adjacent level stenosis, I think the $1 million question is fix or decompress alone. And again, here I'm going to stick my head out and say we fix too often. Like mostly it's a default setting that if this is a redo, I'm going to extend the fixation. But in reality, you need to fix only maybe 30% of the times. In the majority of the times, you get away with decompression alone. Look for hard signs of instability. Most likely, like this one's falling into lordosis, there's really no reason to, to fix. So when you plan the decompression here, once again, look at your landmarks, identify the spinous process. The screw becomes a great landmark intra-op. So if you can identify the upper screw, you know just above that is going to be a pars, and then you're going to find the spinous process, and then you know the area of your decompression. And here, once again, it's good to attack the normal area. So once you know that this is the spinous process I need to sacrifice, you go above that spinous process, go into the normal space above that spinous process, then exterminate or remove that spinous process, and right at the end go into this this region, which is not the fun region. Now the picture on the right depicts bone on the lateral margin. So when you actually take the spinous process out, the next thing you want to do is walk through the, keep your eyes on the picture on the right, walk through the bone available on the sides and work on the sides. But again, on this x-ray you see the bone on the right is far more hefty and robust than the bone on the left. So use that, don't walk on a narrow path. So use that bone which is robust, and then go into that space, the contentious area where you're going to have fibrosis, and where the last surgeon has gone through. Sorry, I'm going to just run through. There are many slides. I want to tell a lot.
Please carry on. Don't worry about that part.
So localization can sometimes get tricky, especially in discs. So this is a very straightforward scenario, but this is not a straightforward scenario. You see the disc is leaked out at the adjacent level, but it's gone superiorly. So here you got to actually go to one level above. You can't be doing what you did for the other case. You got to do a laminectomy here. And if you miss that and just start digging around here, you're going to totally miss that. I have missed a disc like this at least once. I mean, I'm sure I've done more times. So you got to localize an adjacent level disc prolapse far better than adjacent level LCS. So that's a red flag in your head. If the adjacent level disc prolapse, find out where it's sitting. Is it in the axilla? Is it gone up? Is it gone down, etc. Now the third scenario, same patient, different surgery in the same region. Again, this is not so uncommon. You've done a laminectomy, and over time this person has actually dislocated and become listhesis. So you have to go in and just do a fusion. It's a different surgery in the same region, but you can treat it differently. In the sense, you don't go to the region, you rather go stay away. So these are videos that depict you don't go into the neural zone at all, because the decompression is good. Most of the times you don't need to go and re-decompress. It's either infection, hematoma, or some instability that's happened. Work on the sides, work on the bones. So stay fully away from that. Just leave a lob of scar tissue in the middle. Don't even visit that the neural structures. Work on the bone, find your pedicle, find everything, and then in the end, if you feel like, you can still visit the scar tissue. But the idea is to stay far away from the zone of discomfort, or sometimes even bypass. This is a common question that gets asked. A failed vertebroplasty, how do you access that cement and how do you take it out? You don't need to. That cement can stay, and you just bypass that cement. So often you can get away by not actually getting into the thick of things, and maybe get a slightly inferior result. Like this case, there's no anterior support, but this is an 80-year-old gentleman. It's okay. If you do a long posterior fixation, you can get away by not messing around with that cement and try to take that big blob out from the back, or then approach it from the front. And then don't repeat the same mistake again. This is our patient. We did pedicle screw fixation, corrected his kyphosis, but the screws were walking out. You can't be doing screws again, and they're going to walk out again. And you got to think out of the box. I know we hard sell the wires a lot in our unit, but they really, really are the magic pill for a person with bad osteoporosis, especially in the redo. And then finally, same surgery, same patient, same region. Those are the tough ones, and these are the ones who come with post-op inadequate relief in pain, or patients who have a post-op radiculopathy or a deficit. And here I think the key question which Vishal touched upon is, when do you do post-op imaging? An urgent imaging is needed if there's a neurodeficit. A semi-urgent is needed if the post-op worsen in radicular pain, not back pain, but radicular pain. And if there's inadequate relief, you kind of float around and in a few months do the MRI. Because post-op MRIs always show something. You can do it as an experiment, do an MRI and your best result, and it'll show something. And it'll be reported also. So don't get carried away by the report of the MRI. Now here's a case with 3-month follow-up who came with excellent result, but she thought कि MRI हर 3 महीने करना है. So she got an MRI. It looked so ugly. The MRI looks crap post-op, but she has like 0 symptoms. So just a lesson learned. So here's a case with a post-op clean discectomy done, but developed a lot of pain, radiating pain. So the question here is, will you do a contrast MR or a plain MRI? And I'm going to again stick my head out and say that there's no need for a contrast MRI at all. Until you're 6-7 months down post-op, contrast MRI is a waste of time. You're just looking at the bulk. You're looking at, if there's a bulk of tissue there, you don't need it to light up or not light up. And there's no scar tissue forming in weeks or in months. So I'm going to like sternly say, don't waste your time with, because contrast will show so many things that you'll get totally misled. So do a plain MRI, find out if there's something sitting there and go after it. Like this was a failed endoscopic. I like to keep showing all the endoscopic discectomies that have failed because I strongly believe that we've still not gone over the learning curve of endoscopic discectomy. And here you can see the post-op MRI is again another one, adequate, simple, non-contrast MRI. It adequately shows you what you need to do. The mass effect of the disc, go and address it and you'll get it out. What do you think this is? So it was hematoma, but sometimes it can be a gauze piece, so you got to be careful. If it's a delayed presentation, you got to do an MRI, and we all know there's a halo sign. If the disc shows a halo sign, which means the contrast lights up around the disc, it's going to be a recurrent disc. If it doesn't light up, it's bright white, don't touch, because you're going to create more scar. It's just going to be plain scar tissue. You're going to have a bad result post-op. Right, so if you then have to do this surgery again, the technical tip here is again look for bone, and invariably you'll find that a lot of bone has been left behind by the surgeon, because it's a redo. So a case like this where a laminectomy is done but the nerve roots haven't been released, this is your advantage. When you go again, you work on the bone, stay on the bone and start hammering it down from the side. So again, you're not walking into the thecal sac, you're going on the side, finding the chunk of bones on the side, hammering it out, going laterally to the virgin area and then addressing your disc or whatever else you need to. So that's the pro tip here. It can get difficult because the tissue is stuck, but you got to use your hammers and chisels well, and you can then separate it nicely. Rarely, or when you're not so experienced, you can actually go far lateral, take the whole facet off and then fix. That's one way of, it's an escape maneuver. And if it's a redo, same surgery, same location, implant patient, you got to do a CT scan. You can't do it without CT because you'll find strange, strange things. And in cases like this, which again you'll get more and more of, don't write off these screws. Like here, don't write off ke ye screw gaya, ye pedicle milega nahi. Invariably, the pedicle has been missed, and you can thread a pedicle at the same level. So back yourself to finding the pedicle, especially if you've done it in an exposed manner. And they are not always easy. This is one of my really bad cases where I went in again, the cage kept vomiting. I mean, for want of time, I'm sparing you the gory details, but you can see where we have ended up. A unilateral Steffi plate with some bone in the middle with some funny screw going across. So they can get tricky. And then the final frontier, which if you want to know, is revision deformity surgery, which can really take your case, as they say. Like here's a case which is a broken H rod. Like how do you address this? Because this kid has been living with this for almost 6 or 7 years, and then you go in and it's like the surface of the moon. There are no landmarks. So what we use here is these 3D printed CT jigs, and they help us find out the landmarks because inside there's just sheets of bone. Another one failed Duque trolley, if you all know what that is, and they fall into kyphosis. It works well initially, but it falls into kyphosis. Very hard to get these landmarks in, and you should use either navigation or CT or some such. Another one with this is a good technique to follow if you're doing a redo kyphosis, which means that if the patient is fallen in and now getting a neurology. This kid had been operated before by Professor Tully actually, and he had done a very nice posterior fixation, but the kid grew, and that gave rise to this big sheet of bone at the back. So I'm just going to show you a quick visual. You cut the TPs, cut the ribs. It's almost like doing an N block, and then access the gibbous, and then you can take the gibbous off completely. You don't have to again go in the middle and take that sheet of bone from the center, and at the end you get a very good decompression. And this is of course my star case. It's a very badly kyphosed, fixed cervical kyphosis. Again, the options of surgery are very limited here, and we used the same technique in the cervical spine, went laterally and took the gibbous down, and you get a good result because the patient, the cervical spine was stable. So to take home, I think appropriate, well-timed radiological diagnosis, so get MRIs, X-rays at the appropriate time, good clinico-radiological mismatch. A lot of our spine patients scrib. It doesn't mean they all need a redo. So you make sure that you have the problem and the pathology nailed. Counsel the patient well, especially if it's someone else's patient. Decompress or fix is the question to be answered. And the technical tips of levels, bony landmarks, and going from normal to abnormal. Sorry for overshooting time, but I enjoyed this lecture. Thank you.